Thank you for joining us on our first live Scoping Sunday session. My name is Ramzi Mulki. I'm a gastroenterology fellow at Emory University in Atlanta, Georgia, and I'll be co-moderating this session this evening.
And hi, everybody. I'm Malorie Simons. I'm a gastroenterology fellow at Johns Hopkins in Baltimore, Maryland, and I'll be co-moderating with Ramzi this evening.
So we're living in unprecedented times. Trainees across the world have been impacted by this pandemic in many ways. However, these difficult times and our eagerness to learn led to the social media collaboration of trainees and faculty members across the world.
For those who are not familiar with us, Scoping Sundays is a Twitter handle founded by Mohammed Bilal, who is an advanced endoscopy fellow at Beth Israel Deaconess Medical Center in Boston, Massachusetts. It is led by a tutorial board composed of a group of gastroenterologists in training who share the same passion for collaboration and education.
Today's live lecture would not have been possible without the help and guidance of Mohammed Bilal and Ahmed Bazarbashi. Ahmed Bazarbashi is a gastroenterology fellow at the Brigham and Women's Hospital in Massachusetts. Now, before we introduce our speaker, we would like to go through some housekeeping rules.
So first, make sure you remain muted, and if you can, keep your camera off to avoid any distractions and to make sure Zoom doesn't crash on us. Second, we want to make sure we have time for questions at the end. If you have a question, please send it directly to Ramzi if the first letter of your first name starts with A through N. If the first letter of your first name begins with O through Z, then send the question directly to me, Malorie. For example, if your first name is Mark, you can send the question to Ramzi. We will identify the most commonly asked questions and themes and direct them to Dr. Berzin at the end of his talk.
Now, without further delay, it's a pleasure and honor to introduce Dr. Tyler Berzin. Dr. Berzin is a co-director of GI Endoscopy and director of Advanced Endoscopy Fellowship at Beth Israel Deaconess Medical Center in Boston, Massachusetts. He's assistant professor of medicine at Harvard Medical School as well. Dr. Berzin is a well-known expert in advanced endoscopy and has authored over 100 articles and chapters on topics ranging from the quality and safety of GI anesthesia to applications of artificial intelligence for colon polyp detection. At Harvard Medical School, he has been the recipient of numerous clinical and classroom teaching awards. He is a renowned endoscopist and a master educator. We are very thankful for taking the time out of his busy schedule to support Scoping Sundays, our fellow-driven initiative. Thank you, Dr. Berzin.
All right, folks. Well, listen, first of all, I'd like to thank all the fellows behind the Scoping Sunday platform for taking such an innovative approach to engage everybody in our field. It's really clear that you folks are defining a new path of collaborative learning for gastroenterology, and it's really awesome to see how these technologies can pull a global community of gastroenterologists together. So huge congratulations. Second, I want to acknowledge that we're all really on a path of learning in our field, all of us, I think, at different points who are on this call in the US and internationally. There's a huge range of expertise in the audience today. You may see or hear something from me that you disagree with, and I hope that we can all learn and discuss it here and also on the Scoping Sunday platform. We're all here because we're committed to our patients. We're all trying to help each other learn to become better physicians and endoscopists. That's a pretty great thing to be part of, and I'm pretty proud to be a part of it with you guys today. So, so Dr. Simons, Dr. Mulki, Dr. Bilal, Dr. Bazarbashi, let's do this.
All right, thank you.
So you should be able to see our first slide. And the number one thing I'm going to tell you about this talk is that this is not going to be a gee whiz, wow, look what I can do polypectomy talk. What I really am more interested in is communicating some of the common stuff that we all deal with and trying to make sure that we do that well. Frankly, it's far more important that we deal with small and common polyps effectively than if we do that rare ESD perfectly. It's all important, but let's talk mostly about the stuff that impacts more of our patients on a daily basis. These are my disclosures briefly. Really everything I'm going to talk about today is summarized in this slide. I'm going to show it at the beginning and the end, mostly as a reminder for you that this is an incredibly helpful reference. References on the bottom of the slide that was published during the last year, and I think it is sort of the best representation of our current thinking of managing small to large polyps. So we'll dive into it. So let's talk about the challenge of polypectomy, and I see the challenge of polypectomy really as a story of three key polyps. The small flat polyp, there's a risk of incomplete resection. Should we use forceps? Should we use snares? The large pedunculated polyp, should we use detachable snares or clips when we remove those? And then sort of the classic one that is always hard is the large flat polyp, and we're going to talk about how we can use narrowband imaging and advanced light to make decisions. We'll talk about choosing snares and injection solutions. And then we'll also get into some recent data about edge ablation and clips and cautery settings. So why does the small sessile polyp matter? Well, for all of us, it's the most commonly encountered polyp during colonoscopy. And it also is actually among the most likely to be resected incompletely, especially with piecemeal or forceps attempts compared to a pedunculated polyp. The other concept that I think is really important is the concept of biologic age of a polyp. So you could get 98% of the polyp, but the polyp that is left over, that still ages over time. And I think of this really in the same concept we think of as a bonsai tree. So this is a tree that is very small, is pruned over time, could be 80 years old, 100 years old, 200 years old. So even though it's small and people are taking off little pieces of it, the age still remains, and that is a concern when we incompletely resect a small polyp. That small piece, next time you look at it a year from now, it might still be small, but it's aging, and really the goal here is to get rid of the entire polyp so we arrest that aging pathway. So, so the first question I have for you, and you can answer your responses in the chat function, and Mal and Ramzi can provide me with your estimates. But the question is, what's the likelihood of incomplete resection? In other words, some residual adenoma for an 11 millimeter sessile polyp. And those are options there, less than 5% to up to greater than 20%.
So we have some answers already, Dr. Berzin. D, a lot of people are saying D, including our advanced fellow at Emory. Who else do we have? Several people are saying C, D, yeah.
So I'm glad that you folks are estimating on that side of the spectrum, because that's the right side of the spectrum to think about. And this is there's actually some fairly clear data about this that is worth being aware of. I think one of the best studies that we have is this study that was published in 2013 in gastroenterology. And this was a study of incomplete adenoma resection on 1,400 patients who had polyps ranging from 5 to 20 millimeters in size. And the endoscopists were asked to do what they normally do, their best practice, to completely resect the polyp. And then after they were happy and done, then they took additional biopsies at the resection margin. And the nice part about this study is that it included mostly really expert endoscopists, but some academic, there are a couple of community folks, but these are all folks who are really good at what they're doing. And so the results of this probably are maybe generous in terms of what we found. And so the finding was that there was a rate of incomplete resection that ranged between 6 to 23% between endoscopists. And when I just look at this number, one of the first things I think of is that we all have an opportunity to improve. From the best to the worst of us, there's an opportunity for us to move along the spectrum towards zero, some of us more than others. What were the factors associated with incomplete resection? There are really four. One is the piecemeal resection was a higher rate of incomplete resection versus en bloc. Size range, 10 to 19 millimeters in particular, was at risk. SSAs, sessile polyps, were more likely to be incompletely resected. And then again, there was variation by endoscopist, which is really important to know. So I think the three key points that I see from this really important study is that incomplete resection is common even for relatively small polyps. On-block resection is best when it's feasible, and most endoscopists have an opportunity to improve technique towards that highest quartile or quintile of successful polyp removers. So, so tomorrow, or when your endoscopy suites open up, whenever that is, all of us may face a polyp that looks like this. And so I think the first key question, and maybe the most common question we all face during a screening or surveillance colonoscopy, is should this be removed with a cold forceps or a cold snare? It's worth talking a little bit about the techniques for a moment before we all make a decision. The technique of a forceps we usually use a large or jumbo forceps, and the concept is just to take a single or multiple bites until the whole polyp is resected. And the big advantage is we all know it's pretty fast, it's safe, it's easy. You don't usually lose your specimen. A disadvantage is that we may be taking a smaller resection compared to the snare. With a cold snare, the technique obviously is different. It typically, most commonly, will use a fairly thin wire, small snare. You can do this with a 10 or 15 millimeter snare. A couple of important things. One, it's really important here to keep the lumen inflated. That limits submucosal tissue trapping. Position is really important here. We really focus on trying to get the polyp towards 6 o'clock for this to be successful. And then you're pressing down and pushing the sheath forward as you're closing to try to get a good margin. And we're really trying intentionally to get normal tissue in addition to the polyp. The advantages, again, is you get a larger area of tissue, hopefully a clean margin. The disadvantage, and we've all faced this, is that you may lose your specimen as you're positioning. Sometimes it'll fly off into a pool of water. You could spend 20 minutes suctioning. And my thought is that in general, getting the polyp off definitively usually is more important than getting the pathology specimen. Ideally, we have both. But if you have to have a choice, I'd rather just definitively get the thing off. So this is a video of what an ideal cold snare polypectomy looks like. And you're going to see the polyp at 6 o'clock in position. And we're first positioning the snare, but we're also waiting a little bit of time for the lumen to fully inflate. And once the lumen is finally fully inflated, then as the snare closes, the sheath can be pushed forward. You're pushing down on the tissue and going through. And that's really what an ideal cold snare looks like. Now, the European guidelines in 2017 suggest that we always use a snare. So we use cold snare for removal of all diminutive polyps, and only biopsy for polyps less than 3 millimeters, maybe if the snare is not technically feasible. And I think an important question is this reasonable, or is it over the top? What do we know about the effectiveness of snare or biopsy forceps for small polyps? There's also pretty good data around this, and this is a randomized trial that was published a few years ago in GIE, looking at cold snare polypectomy versus cold forceps polypectomy for really small polyps. And it was a randomized trial, and the key finding here was really that for adenomas that are tiny, less than 4 millimeters in size, the cold snare and forceps complete resection rate was actually very similar. And the big divide happened more at 5 millimeters and beyond. So, so the way that I think about this in general is that for a really tiny polyp, I think you're fine to use a forceps, you're fine to use a snare, you can use whatever you wish. If it's really tiny, I still prefer using a snare if it's technically easy, but I don't lose sleep over using a forceps if I need to. Starting at 4 millimeters, I really think it's time to start using a polypectomy snare. And greater than 7 millimeters, you'll see my personal preference is actually to use a hot snare, but we'll get into that controversy in a little bit. What about the large pedunculated polyp? This has its own challenges, and one of the big challenges is the concern for a blood vessel in the stalk. And so we often think about pre-treating polyps like this, either with a detachable snare to strangulate the polyp first, or potentially clips at the base beforehand, before we do the polypectomy. And this question has also been looked at actually in a randomized trial. where almost 200 patients with large pedunculated polyps were randomized to either clip or endoloop, a detachable snare, prior to the polypectomy. And there was actually no difference in bleeding rate at all between those two choices. So the truth is, you can choose either. And I'll later argue that you can choose none of the above too. I want to make a quick point about the detachable snare. Of all the equipment that we use in the endoscopy suite, including in our advanced endoscopy suite, I think this is one of the pieces of equipment that most commonly misfires. And the reason is we don't frequently use it, and often our nurses or techs are not comfortable using it. So I always tell people that if we're going to use this, we have to bring two into the suite, one to fire accidentally and harmlessly next to the polyp, and then the second one we actually use correctly. But there is actually a good way to remember how to use these, and the steps that I ask people to remember is the ABA method. And the basic concept is that the first A is moving the yellow cylinder away. The second A is moving the yellow cylinder back to you, and then the handle slider back and away. And I'm going to show you a video of what that looks like. In the package, it comes with the snare open, so you have to use that first A to get the snare sheathed. You then go ahead and open the snare in the lumen. That's the second A, yellow cylinder back. And now you position the snare around the polyp. This is when you use the handle slider. You move it back to close the snare over the polyp. And this is a one-time move. You can't reopen it at this point. Now your only choice is a way to release the snare. So that's the last movement of this. And we actually have this picture posted in our endoscopy suite, the ABBA method, because it helps us use this more reliably. So the key points for the large pedunculated polyp is strangulating the base with a snare or clips may reduce the bleeding risk. I think clip placement, honestly, is probably easier and equally effective. What do I do? For a stock that is small, I just snare it and have clips ready just in case. For a really thick stock, I think we have three options. You could still just do the snare, maybe do epi beforehand and then just use clips afterwards. A lot of us still just use that, and that approach I think is safe, although it hasn't been part of that randomized trial. But you also have the choice to place clips or do a snare prior. The truth is we have all of these options. They're all reasonable to do, and you should do what's most comfortable for you. So this is a sad moment for all of us in endoscopy, but there are times that you can run into a large pedunculated polyp here, for instance, in the sigmoid. You try a snare polypectomy and nothing seems to be happening. And when that occurs, there are 4 steps really for troubleshooting that snare that won't go through. The first is to check the circuit. You can consider exchanging the grounding pads or the wires and make sure everything's plugged in. The second, if you have not been using any blended current, to add some cut or blended current, and sometimes even we'll change out a generator to see if there's a generator issue. The third option is to try opening the snare and just releasing the polyp, and hopefully you can do that. If steps 1 through 3 do not work, you have an impacted snare and you are sad. But it will happen to all of us, and it's important to know how to handle that. There are a couple of approaches to thinking about this. The first, and I think generally the best, is to cut the snare. There's a scissors shown in this picture, but a wire cutter is better. But to cut the snare at the instrument channel, and you withdraw the scope, and then you reintroduce the scope and use a new snare just to begin piecemeal from the top of the polyp down until you get to the base. So that is a reasonable choice to consider. The second, slightly fancier option is to do the same thing, cut the snare at the instrument channel, withdraw the scope, but then insert a second snare through the scope channel before you've even replaced the scope. So the scope is outside the patient. You insert a second snare through the scope channel, you open it up around the wire, and if you do that and then thread this forward and introduce the scope, this can now find its way all the way around to the base of the polyp. This is a little bit fancier to do. I think honestly it's a little bit fickle and troublesome, but it's an equally reasonable option. I should mention that if you don't have any of these options, one of our major GI textbooks suggests a third option, which is that if you can't get it off, you just leave it there and you admit the patient to the hospital and you wait. In a lot of cases, the snare may eventually fall off. This is a harder thing, I think, to explain to a patient if you have a snare wire taped to their butt and you say, you know, I have good news and bad news after your colonoscopy. It's not a conversation most of us want to have, but it's not crazy, and it's still at least a safe consideration for a patient, certainly before surgery. All right, so let's talk about the large sessile polyp. This is often what gets most of the attention during polypectomy talks. You know, I think the key questions that we have to think of when we face a large sessile polyp is, number one, is this endoscopically resectable in general? And then the second question is this endoscopically resectable by me today? So let's focus on that first question first. So regarding whether a polyp is actually endoscopically resectable, there's really not any strict size limits anymore. You can have nearly circumferential polyps that can be resected. Really, I think the key issue is more the presence or absence of invasive cancer, and that's the core question that we're trying to get at. So I'm going to show you a video here, and this is another thing that you can use the chat function with Ramzi and Mal to provide your answer. But I'm going to show you a video of a polyp, and you can let us know whether you think snaring this, EMRing this, tattoo only, or tattoo and biopsy. And we switched over to NBI here to look at this thing. So Ramzi and Mal, any responses coming in?
So a lot of, from my end, I'm seeing tattoo and biopsy.
Mm-hmm.
I guess a big portion not favoring EMR for now.
Yeah.
I'm getting mostly D's, mostly
Good.
D.
Good. I would go with mostly D too, and I think mostly D is almost a perfect answer, because I think we're not going to get into ESD world, but today, but there could be an argument to think about. See, I'm going to go for D as well, so I'm with all of you. And so I want to talk about what I think of the best way of evaluating polyps now. And you know, I always show this map of France and say I think it's time to leave Paris and find a simpler life in Nice. So what do I mean by that? Well, the Paris classification is widely used internationally. It's a nice, consistent way to describe a polyp. But I'll tell you, as a United States endoscopist, and our colleagues internationally may be appalled at my saying this, but the truth is this is not widely used at all by US endoscopists. We tend to use lots of subjective descriptors. We try to be good at it, but the Paris classification is not widely used. And I think part of it is frankly, it's a little bit bulky and sort of non-obvious. So I think that a more reliable and simpler approach to get right most of the time is instead to use this NICE classification. And the concept of this classification is that there are really only 3 types. We use narrowband imaging to identify this. And type 1 is basically a hyperplastic polyp. It has a few isolated lacy vessels in it and sort of even spotting. Type 2 tends to be browner. You see some brown vessels within it, and then you see almost a cerebriform or brain-like pattern. This is an adenoma. And type 3, the key thing is really you start seeing disruption in the center. Some of the blood vessels that you could previously follow are disrupted. The surface pattern is amorphous and weird. Sometimes you'll see tiny little ulcers, and this is a type 3. And so from my perspective, if you encounter a large polyp, really what you want to do is put on your blue light and use this pattern to make your decisions. A type 2 polyp, you can either choose to prepare for an EMR if you're going to do it then, or you can tattoo nearby the lesion, not under it. And type 2, you really only need to biopsy if you're uncertain about what you're seeing. If you're pretty certain about what you're seeing, the better thing is not to biopsy it and just to prepare for your EMR or refer it to your colleague who's going to do the EMR. Type 3, when you're beginning to suspect cancer, this is the moment where biopsy is appropriate from my perspective. And again, you can get into worlds where some would argue not to biopsy this, and there's a chance that ESD may be helpful, but I'll say that for most of the world, biopsying and tattooing type 3, I think, is the right thing to do where we stand now. Talking about tattooing is not super exciting, but it's actually really important. And this is an area where there's huge variability in how we do it. The key concepts are location, documentation, and technique. The location piece is we want to choose an area, usually around 3 centimeters away from the lesion. That sort of guarantees that your injectate is not going to go under the polyp. And you can choose distal to the lesion or distal plus proximal if you'd like. And then our surgical colleagues will often suggest that we also tattoo at different orientations within the lumen, because one orientation may be more easy to see for during laparoscopy than another. Really important is to document very clearly in your note, not just I did a tattoo, but rather to be specific. I tattooed spot ink 3 centimeters distal and 3 centimeters proximal to the mass, so people really know what you did, and when they encounter the tattoo, where to find the polyp. And then finally, the technique, which I'm going to show you on the next slide, is really important to try to aim for the submucosa and to avoid peritoneal injection. This is a nice article from Dr. Rex in 2018. And there are really 2 methods from my perspective to do ink injection. The first is to first create a bleb just with saline. Because once you have found the submucosa with saline, you're guaranteed that the ink will go in the same place. And actually, historically, older formulations of ink used to cause pretty profound peritoneal reactions. And so it was really crucial to get it in the right place. Now we're spoiled with the current ink formulations. It's less likely to cause peritoneal inflammation, but you still want to get it where you're aiming. So a little bit of saline will help you find the submucosa. If you don't use saline, then you have to take extra caution to try to enter the needle fairly tangentially, pull back a little bit. You're trying to get just a little bit of tissue and a little puff of fluid, so you've confirmed that the submucosa is the space that's expanding. Of all of the layers of the colon, the submucosa is the space that wants to expand. If you inject in any of the other spaces, they're not going to take up much fluid, and it'll either go through or onto the surface. But if you find the submucosa, that is expansile, spongy tissue. It wants to take the fluid. So a successful tattoo will look like this for the surgeon, and an unsuccessful tattoo can often lead to lots of peritoneal staining and just is, embarrassing for the endoscopist. All right, so let's talk about dealing with this polyp again outside of tattooing. So if you're thinking about removing a polyp, I think as an advanced endoscopist, I ask myself 3 key questions. Is this resectable by me today? In other words, do I have the time and equipment and staff to resect this polyp today? And the third is my patient and their family aware of the risk of endomucosal resection? If this person is on a screening or surveillance list for me, and then all of a sudden I encounter a large polyp, those of us who are comfortable doing EMR often have this tension of saying, well, we could just take care of it. The patient's already undergone the prep. Wouldn't that be great? I'm sure they'll appreciate it. But the truth is our normal colonoscopy consent, or my colonoscopy consent, doesn't really go into all the details of an EMR in terms of bleeding risk and perforation risk and so on. And if I'm bringing somebody in for an EMR, I'm usually asking them and their family to make sure they're not traveling out of town that week or taking an airplane tomorrow or any of those things. And I have done EMRs on patients where I didn't talk about all those things ahead of time, and then they did get on a plane the next day, and then they had to bleed 10 hours away from me by flight, which is not what I want. So even though it seems like the convenient thing, and it really obviously depends on your local practice, in my practice, I'm really thoughtful about whether this is the moment to do the EMR if I was not expecting to encounter this polyp. Many of you practicing internationally may be in locations where you have to do your best for your patient during that moment that they're with you. And I think that's a very reasonable time to do an EMR, especially if you've included all options in your consent. So what about the submucosal injection solutions? The most common, the classic is saline plus some sort of dye. We often use methylene blue, and in our particular formulation that we'll often use is here. But there's also a movement towards proprietary submucosal agents. The big advantage is that there's a longer submucosal lift, and there is data now to suggest that these are better approaches. There are major cost considerations with submucosal lifting agents. I'll tell you, in the United States, it's gotten complicated because methylene blue itself has become expensive. So these are more cost equivalent than they used to be. But it's still important to know that you have the choice. Other pieces, it's really important to understand your equipment before you do an endomucosal resection. There's a huge rainbow of snare choices, and we often throw around the terms soft and stiff, but there are actually no strict definitions of what that means. I've listed a handful of example snares here, from softer to stiffer. There are many more, obviously, throughout the world that fit somewhere on this spectrum. I think the key thing is to understand what you're working with and to make sure you're working with something that's on the stiffer side if you're going to do an endomucosal resection. There's an issue in terms of how companies describe these. So this is just an example of a snare that is labeled as a soft snare. And this is another snare which is from the same company and has no label at all. And so you have to assume, because it does not say soft, that this is therefore regular. And so packaging among all of these snares is a challenge. The other challenge is size. Snares that are packaged as 10 or 15 or 20 millimeters are not always 10 or 20 or 15 millimeters. I encourage all of our endoscopists to, whatever tool you happen to use, to at least at some point, whether it's a forceps, a snare, you name it, get it out and put it next to a ruler so you really know what you're dealing with, and you may be surprised at the sizes of the devices you're using. So how do we stock our own endoscopy unit? We try to really keep it simple. We have 38 endoscopists on staff at Beth Israel, and if we were utterly flexible about things, we could stock 100 different snare types. And I don't think that's a good approach either for the endoscopists or for the nurses or technicians. I think the truth is you can do 98% of what you need to do with a couple of snares. We think of our 15 millimeter oval, a regular stiff snare, as sort of the workhorse that can do nearly everything. And then we'll have a few dedicated secondary snares, but I really encourage, especially if you're in a larger unit, to try to get simple as opposed to get complex in terms of the snares that you choose. So in terms of the basic EMR techniques, key concept again is to find that submucosal space. Similarly to a tattoo, you want to inject slowly at first to make sure you've found that space, and you're looking for that lift to happen. And you really, the biggest error that I see for folks that are not doing a lot of EMR is honestly not to inject enough. I think being aggressive with the injection is pretty important. So again, we'll typically most commonly use a 15 millimeter snare. There are many people who prefer much larger snares, and they'll take almost anything off on block. I think Dr. Bork and many other experts around the world have shown that using sort of a medium-sized 15 to 20 millimeter snare is a good compromise between safety and efficacy. Anything larger than that, and I think there's a risk that you may grab more than you have control of. So I generally favor using this snare size. I've shown a hexagonal snare in this picture. The truth is I tend to prefer oval snares. And the steps, and you saw it for the cold polyp, but you really need to press down fairly firmly at the base of the polyp. You can use either pure coag or blended current. We'll talk about that more in a moment, and just try to get through the whole thing in a single continuous cut. And then you work from your resected edge and keep on moving if necessary. This is a video of first just the lift of the polyp, and honestly, a third of the video is just lifting, and it's important to see that you really have to lift these a lot. The second reason I show this video is because there are sort of two schools of thought about where you should start. Should you start on the distal edge away from you, or should you start on the edge close to you? And there are reasons to do either, and different situations to do either. I often actually prefer doing what's shown in this video, which is to work on the edge closest to you. The reason for that is that you have the most control of where your snare is placed on that edge, and you'll see how precise we can be here to line up exactly with that edge that we're working with. And I love that visualization to have, so I tend to work away from me and then working away. But there are times where that away thing is so difficult to see, you want to start with the hardest part first, but there are arguments to be made on either side. So after you've done this beautiful looking EMR as shown on the right, the question is, are we done? And you know, the clear data from the last year is that you're not done. The important tip here is that we have to ablate even those clean looking edges to reduce recurrence. In this study, the use of ablation dramatically reduced the risk of recurrence from 20% down to about 5%. So that's a big, big difference for a small intervention. In the study, they used the snare tip. I think most of you internationally probably use the snare tip as well. In the United States, where we sometimes are a little bit more wasteful with tools, some of us will use argon plasma around the edges, but they accomplish the same thing. So now we've done our thermal ablation. You see a nice, a beautiful picture of thermal ablation around the corners. Now are we done? And so now the big question is clip placement. And this, there are many, many studies about clip placement, and there have been some variable results to these studies. I think the largest and best study is this, which came out in the last year, showing that at least for large polyps in the right colon, that clip placement is the right move. And there's lots of subtlety here that's not built into this slide. If you have a patient who's coming from 6 hours away, who's gonna, it's gonna be difficult for them to come back to you if they have a bleed, if they need to be resuming a blood thinner earlier. These are all considerations, I think, where we have to decide whether clip placement is reasonable. And the local cost of our clips, I think, also plays a big role. A lot of people don't realize that the recent study that came out looking at yellow versus blue petal, or endocut versus coag, is actually the same study as this clip study. This is a large randomized study. It had a 2x2 design, so it looked both at clips and at endocut versus coag. And they found no difference in the clinical outcomes of using a cut versus coag, or blended current versus a coag current. I tend to like using an endocut. You can find people who are extremely passionate about using an endocut for large EMRs, but the truth is the evidence doesn't yet support that passion. So it's okay to be passionate about it, but the data is mixed. The cold snare revolution gets a huge amount of attention, and we have to talk about it. I'm sure there are many people who are on this presentation today who are cold snare experts. And I'll tell you first about how we think about doing a cold snare. The first is you can use your submucosal lift agent of choice. Some people like to add a little bit of epi, and I've written down here on the slide how much to add for certain concentrations. You have to use a fairly small snare. If you use something too big, you may just get stuck. It should be a cautery capable snare in case you get stuck. And you want to aim to resect at least 3 millimeters of normal tissue margin. And then you have to sit there and watch it for a little bit to make sure there's no bleeding. The beauty, of course, is that if there's no bleeding, then you're very unlikely to face bleeding a few days down the road. Is this the way forward? Early non-randomized data suggests that this may reduce the risk of bleeding and reduce the need for clips. So that's appealing. We don't really know if piecemeal cold snare of large polyps is going to have a different recurrence rate compared to hot snare. It might be lower, might be higher, might be the same. Personally, I still prefer hot snare EMR. I'm awaiting randomized trial evidence, and I might give this talk next year, and I'll tell you that I'm ready for cold snare EMR, but I haven't joined the revolution yet because I don't think the data is quite there. It's worth getting into a few fancier things, and we're nearing the end here. Full thickness resection is now possible for non-lifting polyps and recurrent polyps. And I think that this is actually most appealing for some of these smaller polyps that have been partially resected and sort of keep coming back. You know, I hate to send somebody who has a 1 centimeter polyp that it's just a little stuck on the colon because it's been resected a few times. I feel so bad about sending that patient to surgery because it's not a big thing. But a lot of patients with recurrent polyps do get sent for surgery, and this is a really nice nice device for that. The general concept of this device is that you're basically placing a clip and then cutting. We usually think about cutting and then placing a clip, but this places a clip and then cuts. And I'll show you what a video looks like. So, so this is the device. You have a forceps that's grabbing the tissue, and then in a moment, the clip is going to fire around the tissue. It's a fairly dramatic moment when that happens. And what you're left with afterwards is something that looks like this. You can actually see the peritoneal fat and all of the layers of the colon drawn in, and the sample is somewhere over there. So the concept is really nice. It's not for enormous polyps. It does not replace ESD, but it's a very nice tool to have. The current version of this tool, I think, is still a little bit bulky. It requires a sleeve that is placed on the colonoscope. It's not the easiest thing to use, but it's still a nice device to have. So as a final thought, in 2020, I think it's very clear that far too many people are still having surgery for benign polyps. There, in the US, for instance, there are 600,000 colon resections over that every year, and the majority are still for benign lesions, including adenomas and sessile serrated adenomas that were never evaluated for endoscopic resection in the first place. And it's estimated that 80% of these, if they're referred for surgical resection and they get instead evaluated by endoscopy, can be successfully removed. So, so as much, again, as we can talk about ESD and other advanced techniques, I think that our biggest opportunity, one of our biggest opportunities, is just to get access to many patients who are not having endomucosal resection yet. So, so a few key points, best practices, I think, for 2020. For the small sessile polyp, incomplete resection remains surprisingly common, and you want to aim for en-bloc resection with a cold snare whenever possible. For large pedunculated polyps, if there's a thick stalk, hemoclips may be just as effective as an endoloop to prevent bleeding. From my perspective, you can also do nothing and simply get the thing off if you're really comfortable getting a clip on right away. And I should just add quickly, for the pedunculated polyp, you'd like to leave a little bit of a stalk margin, a few millimeters at least, so you can easily hemoclip that area. For large sessile polyps, I think using NBI or blue light to classify the polyp is more important. And if you're going to only classify it in one way, I prefer that as opposed to the Paris classification. If you plan to refer to it for an EMR, only biopsy. If it's a type 2, only biopsy if you really have a high concern for cancer, and if you tattoo several centimeters away. And finally, if you do perform EMR, make sure to use ablation at the margins and place clips for larger right colon polyps. I started with this picture. I will finish with this picture. This is a really helpful flow diagram that I think nicely summarizes where we stand in 2020. And it's a good reference for everybody. And I think it almost precisely says what I just talked to you about in the last 44 minutes. And then I want all of you to be prepared for a little bit of extra help from AI. We're now beginning to use AI both for polyp identification and for diagnosis. And so I think it's not far off that your next line of scopes, your Olympus and your Fuji and your Pentax and other scopes in the future, just as you have a button to turn on different types of light or magnification, eventually you'll have a button that will turn on this type of functionality. And I think really the goal is just to standardize our performance and help all of us do a little bit better during our procedures. So I will end there and turn it back over to our moderators, Dr. Mulki and Dr. Simons, and I'll be thrilled to answer any questions from there.
Thank you so much, Dr. Berzin. This was excellent. We did actually have a lot of questions come in. Malorie, do you have any? Do you want to start?
Yeah, I can definitely start. So, first of all, thank you. That was fantastic, Dr. Berzin. That was really great. A lot of questions are coming in regarding the size and how to really determine accurately the size of the polyp, because there seems to be a lot of discrepancy with something being 3 millimeters 4 versus 5. And so how do you advise on really getting a good, really exacting the size?
So I think it's really hard to get a precise size. I think the best way to do it is to know the size of your equipment. So when you next enter the endoscopy suite, I want all of you to open a forceps and get a small millimeter ruler and see your forceps and how big each jaw is related to what you think. And the same for your most commonly used snare. And those are the most useful devices. On a two-dimensional screen, it's otherwise really hard for us to measure size correctly. There's actually an endoscopic ruler that is used. It is actually called the Napoleon, and the reason it's called the Napoleon is Napoleon was a little ruler, and this is a little ruler. It's a bad joke. But that's the name of the endoscopic tool. And so if you get really fancy, you can use a tool that's really only useful for trial settings, I think.
Napoleon ruler, great, thank you.
Excellent. Dr. Berzin, I got a few questions about the utility of EUS to assess depth of invasion in laterally spreading tumors, obviously in the distal colon. So what's your opinion on that?
Now, this is an area of continued controversy, and I will tell you that in general, when we're talking about, we have to define what endoscopic imaging by blue light and magnification can answer versus what EUS can answer. Careful evaluation, including using the NICE classification, I think is maybe better at assessing the likelihood of superficial submucosal invasion than endoscopic ultrasound. Endoscopic ultrasound is pretty good at more advanced T classification and seeing if there are lymph nodes. It's not very good at distinguishing, for instance, between a T1A and a T1B tumor. In fact, nothing is really good at that. And often, ultimately, your pathology specimen is the only way to know. So, so there remains a lot of controversy about the role for EUS in staging colon tumors of any type.
Excellent, thank you. Malorie, do you have anything from your end?
Yeah, there were a couple of questions regarding for resection of large pedunculated polyps. If you're going to using hot or coagulation, basically the risk of thermal injury in regards to in placement of clips. So if you're going to use a clip prior to resecting a large pedunculated polyp, does it increase your risk for thermal injury if you do it before versus after? There were a couple of questions regarding that.
Yeah, so that is a really good question, and one that I didn't mention in the talk. There's no doubt that if you have a fairly small stalk, you may not have room to place clips, and I do think that there is a concern that that a clip may sort of create a path of least resistance for electrocautery. So I'll typically only use clips if I have plenty of room to make sure my cautery snare is separate from those. You know, the truth is, I don't think your risk is incredibly high for anything catastrophic, but I would certainly prefer to perform my polypectomy without touching the clips.
Awesome. And Dr. Berzin, we had another question about lifting agents. So normal saline versus viscous agent. Is there any utility in perhaps using a viscous agent for polyps that are less than 2 centimeters versus greater than 2 centimeters?
Yeah, so there are many who, for very, very flat, small polyps, even say a 10 millimeter utterly flat sessile serrated adenoma, will use a lifting agent for that. And I think it's a perfectly good use of a lifting agent. For smaller polyps, not these big EMRs, I don't think there's a big reason to use any of the expensive or starch-based lifting agents for that type of polyp, because you're going to be done with that very quickly, and saline is usually cheapest and works well for something fast. I think the specialized lifting agents are more important if you need a prolonged lift. And again, there is some data to suggest that they can increase the speed at least of EMR and ESD. Whether or not they play a role in safety, I think, is a bigger question, but they can certainly make things more convenient.
Perfect, thank you.
Ramzi, I think we have a room for a couple more questions, correct?
Yeah, go
What do you
ahead.
think? Dr. Berzin, you okay with that?
Of course.
Well, a lot of people are asking about the rule for epinephrine and when you feel like it's the ideal time to use it, particularly with large pedunculated polyps. And when you do use it, or if you do use it, where on the stalk do you normally do it?
Yeah,
or saline. A lot of people are saying saline as well.
So I tend not to inject saline at all for pedunculated polyps. The advantage of epinephrine from my perspective is really twofold. One is that I do think that the epinephrine can cause enough vasoconstriction that a very large sort of unwieldy polyp that is hard to deal with can shrink down a little bit. And in fact, if we encounter a large pedunculated polyp, sometimes we'll inject the epinephrine, continue on with our colonoscopy to finish off everything else, and then come back and the polyp will have shrunk down nicely. So you can often manage polyp size a little bit that way. The second advantage is that injecting epinephrine makes it much less likely when the polyp comes off that all of a sudden there's a dramatic bleed, and I think can give you a little bit of bleeding room so you can, breathing room so you can place a couple of clips without a disaster in front of you. But I think the choice about when to use it is very individualized. There's not any trial data that I'm aware of that's high quality to say that this is when you must use it. So I think it's on a case-by-case basis if I want to shrink the polyp down a little bit, or if I'm really worried that clip placement may be difficult afterwards.
Great. Thank you.
Thank you, Dr. Berzin. I think I have another question regarding your views in the future with artificial intelligence. Do you think there'll be a utility in polyp size estimation?
Yeah, there's some ongoing work on that already, and it's actually one of the hardest things to do. You would think that finding polyps or distinguishing between all the different types of polyps by AI would be the hard part. That tends to be on the easier side. Size estimation is really hard with a single camera, and it's basically because we have a two-dimensional view. If you walk around with one eye covered, it's very hard to estimate the size of things. So there are a variety of different things that scope manufacturers are trying, which range from using a second camera, so there's some stereo vision, to using different types of light projected onto the polyp that can help estimate size. So it is actually one of the bigger challenges for AI than you would think. I think we'll eventually get there, and life will be easier. We won't all be estimating wildly incorrectly, but we're not there yet.
Thank you. I think.
Yeah, I'm with you. I think we are running out of time. The questions that we were asked is, Dr. Berzin, are we going to be able to access your slides? Because people have been really appreciative and really thankful about this talk. I will tell everybody we are recording it, but Dr. Berzin, other than recording, is there any way that we can reference your slides and your talk in the future?
Yeah, so I'll share my slides in a PDF with our moderators and Scoping Sunday team, and we'll let them choose the best way to distribute that to anyone interested.
Great.
Thank you, Dr. Berzin. And on behalf of Scoping Sundays and all the trainees across the US and world, thank you very much for taking the time to give us this fantastic talk. We're also thankful to everybody that joined us today, and we hope to see you in future sessions. So thank you.
Yeah, congratulations to all of you. It's really a pleasure.
Thank
Have
you.
a good day.
Thank you. Stay safe, everybody.
Yes.